We've got a tandem act with Ruth Large, who comes from Waikato Hospital, and is dual trained, and Darren Douglass, who comes out of the ministry, and they're going to tell us their thoughts on sustainability and digital healthcare.
Thanks, Julie. I thought this was very cunning to put a large after a little. But we'll do our best to follow up on that. Stealing some of his words. Look, first of all, I'd like to say thank you very much for having us. Like every good generalist who has a general knowledge, I decided to call a friend to deliver this presentation. So Darren and I are going to tag team a little bit of this. We're going to try and tell a bit of a story. So Renee, you can vet us. Thank you very much. Just a little bit about where we are at the moment and where we could be in the future. With the rider from me particularly that I'm not a technologist. My particular interest is in telehealth, but in digital tools that improve accessibility to healthcare. So I'll rattle through a few slides, Darren will rattle through a few slides, and hopefully you've got a whole lot of stuff on Slido, so we're very slide dominated today. And we'll have enough room for some conversation at the end, yeah? So the themes that we're going to talk about are digital health and measures of maturity, current issues in digital health, national strategy, a bit about COVID and how that's changed. And I like the Minister's point that COVID-19 certainly looked at what is possible with a necessary spirit of cooperation, were his words. Some thoughts on telehealth and the national developments going forward and the National Health Informatics Platform. So this is the Ministry's description of digital health. It's a bit of an old term now, I think. Darren, when does this come from? It is from the 20s.
Yeah, it'll be 2015 probably.
Yeah, 2015, yeah, so it's about 5 years old. But I think it's still true that digital health is the use of digital technologies and accessible data and the associated cultural change it induces to help New Zealanders manage their health and well-being and transform the nature of healthcare delivery. One of the reasons I think this statement is really important is because it's got two great things in there, and that's about cultural change and transforming the nature of healthcare delivery. And those are obviously really, words chosen with care that we should be mindful of, because that is the direction. And again, like every good generalist, I like a team around me, and perhaps not like every good generalist, all of I learned from medicine probably came from the television, and I must have missed the storytelling. But if we think about sci-fi and what it's given to us in terms of digital health, there's an awful lot of stuff that we can learn. And I reflect that many of us sit like our commanders in this huge pool of flashing lights and overwhelming amount of data. And this is what our digital tech has given us. And it's given us the inability to actually be able to direct our attention quite often. So we do get attentional deficits. We've also got augmentation of our senses. So, things like Google Glass are coming out. So there's lots of different tools out there that we have the opportunity to use. And of course, we've got inbuilt telehealth robots, just like the aptly named data. And my personal favourite, the tricorder. And nobody was more excited, except for maybe Willem van der Merwe, to receive a little butterfly ultrasound device, which I now carry in my pocket, and I liken to my tricorder. So, if you think about the digital technology we now carry in our hands, that digital technology is more powerful than the computers that I used at high school, And a good majority of us here, looking around the room, grew up in a very different age to what our junior staff are growing up in. This technology has just changed so rapidly. And yeah, look, this is a really reasonable article. I don't know how many have read this article from Ato Gawande. Yeah, if you haven't, do read it. It is an American, focused paper, but it's a really good one. It talks a lot about screens coming in front of our patients, and admittedly, in America, their computer systems are more designed for billing. So they've seen, and it's a really, really good paper of what to avoid when you're going to do your digital health systems. And we all know that we've grown up in this fractured digital environment. We could blame cheese, we could blame all sorts of things. You know, went through a lot of change when our digital environment was growing. So we haven't got a national platform yet. So you know, there's no doubt that our digital tools have resulted in physician burnout. There's a significant amount of papers published on this, and it's got to do with this uncoded communication that we've developed with our patients, but also information overload. We've got data and more data and more data. We haven't got automated tasks yet. We've got alert fatigue, but also we've got poor digital literacy, and some of that we need to take on board for ourselves. You know, that's actually our baggage too. You know, how we spend our medical education time, I think, is relevant here. And I've got a quote there from Eric Topol, who again wrote the NHS Topol report, preparing the healthcare workforce to deliver the digital future. Again, you know, I don't know how many people have read it. I'm probably a bit geeky. I might be, oh, there's a few hands in the room, thank you. This is a really awesome report. And, you know, I think New Zealand was still in the early adopter phase of digital medicine. And, you know, scepticism is a good thing because we could easily go down that realm, move from, you know, big pharma through to big digital, you know, and invest unwisely. We're all living in our own little silos and want our own little bits of tech. So we need to be cautious of that as well. There's definitely proven value for patients. There's proven value for patients in telehealth, in electronic medicines, electronic vital signs, and probably in an electronic health record, although the information there's a little bit mixed. But nowhere in New Zealand is fully digital. And being half pie is really probably the biggest problem that we have. And we heard from our RMO colleagues yesterday about how, you know, we were transcribing paper into computers. And, you know, I know a number of colleagues who will transcribe multiple times their information. So have a look at that report. I think one of the things also, you know, we've heard a lot about leadership over the last couple of days, and there are very few DHBs who've got roles such as mine, Clinical Director of Information Services. It's got absolutely no teeth, I promise you. I can't do anything. Sorry, Waikato colleagues. But it's a good start, you know, and we are seeing more of these roles develop, and unless we all take a bit of responsibility for that, then we'll get what we're given. Again, I'm sorry, this is an old slide. It is 5 years old. Well, it's a lot older than that, is it? Is it 5 years old? Might be a bit older.
6 or 7.
6 or 7, sorry. But the illustration, I think, is important. We have measures of digital maturity, and we are looking at much better ones, and I'm sure many of you have also looked at the National Asset Review and seen how poorly our technology platforms are based. They're really old. But the interesting thing, more for me, is this gap. So, you know, once you start on this old stage, you sort of see, well, up you get to stage 7, that's a complete electronic medical record, including things like decision support. But this gap here, you know, Southern, Canterbury, Waitemata, I mean, it's awesome that these guys are leading the way, but actually it's not okay for the rest of us to be down here. And that's this gap, I think, we really need to be very mindful of. And I think that gap is probably still similar, even though our maturity levels measures have altered. So I'm going to hand over to Darren to talk a bit about the digital health strategic framework.
Thank you. Thanks, Ruth, and kia ora tātou, everyone. So just one comment on the digital maturity assessments. We've been starting to refresh those with a number of DHBs, and the one thing that I personally didn't like about the 2013-14 iteration was that it gave every DHB a score. So your eyes were drawn to whether you were a level 3 or a level 4 or a level 5. The interesting thing about those maturity assessments is that they're assessed at 7 levels. The ones that we've just done, every DHB we've assessed has got capabilities at level 7, but they also have gaps at level 1. So we're far more drawn to the maturity assessments informing where we've got gaps and where we can improve than whether you're a 2, 3, 4 or 5. The comment that I'd make around our thinking of how do you deliver digital health, and particularly referencing that cultural change, is that the digital health environment we work in is an ecosystem, it's not an organisation. And the rationale behind how you engineer change in an ecosystem is that you don't try to impose structure artificially on that ecosystem, because it's constantly changing and evolving. The technology is constantly moving, organisations are changing, business, clinical need, consumer expectations are changing. So instead of imposing structure, I can get this to work, we have some aspirational objectives and goals, and these are pretty much motherhood and apple pie, looking at what people are expecting, looking at how do we inform clinical decision making, how do we improve health outcomes and equity. And then as a ministry, we focus on these key enablers. So rather than trying to dictate what particular application you should use or what particular type of technology, we are really focused on interoperability, so that there is choice about technology, but there's confidence that health information is accessible regardless of the particular vendor product you're using. We need data standards for that information to come together. We need security, privacy and trust at all times, particularly as we start to talk about empowered consumers. Social licence in this space is hard to gain, really easy to lose. We also need some foundation services, and digital identity is one of those. So if we don't absolutely know who an individual is, we can't provide them with information confidently that's appropriate to their role and to the permissions that they've been given. And then it's not all about the tech. We also think about some of the barriers we know within the sector today. So procuring technology is not particularly digital. It's a very long, drawn-out process and fails to recognise that technology is constantly iterating and changing. So our procurement practices don't really fit a digital world. Our business case approval processes and funding processes similarly don't really fit a fast-moving digital world. And then from an innovation point of view, we have lots of good ideas and lots of little innovations, but we don't necessarily scale them or replicate them very well for whole of system value. And we don't even have the basic visibility of who is doing what. So that means that there's real opportunities being missed. And we think as a ministry, these are the things that we really need to focus on. And just a word around data, we know we've got lots of data, so no one's arguing that we don't have any data. We've got lots of it, but it's really hard to get to. So it's locked up within organisations, within particular systems, and there's variation in how it's collected. So some is only on paper, a lot is digital, but when it's digital, it's based on different standards. And we really don't have a lot of clarity on how do we apply data governance across information when information is able to flow across that entire ecosystem. Our governance structures tend to be anchored around an organisation, a DHB, a hospital, a GP practice. And we certainly don't get a lot of insights out of the data we've got, either from a health system point of view, supporting planning policy, from a clinical point of view, informing decision making, or from a consumer point of view, informing well-being and empowering people. So we use the analogy of where we want to get to, and just bear with me a second on this one. So we talk about a GPS experience. So if you get a hire car in a city you haven't been to before, you hop in that hire car, or you use the map apps on your phone, and you can enter where you want to go, and it'll suggest the right way to get there. It'll suggest some alternative routes. It'll constantly adjust that based on traffic conditions along your way. It will tell you the speed limit, where you can stop if you want a coffee. You can read reviews of the cafes in that area from other people that have been there, and it'll constantly adjust the time to arrive. The reason that we like that analogy as we apply it to health is that none of the data that drives that experience was created for the purpose of that experience. All of that data exists for a whole bunch of other reasons. A GPS app brings it all together in a really seamless and intuitive way. So I don't know about you, but I've never hopped in a hire car with a GPS unit and had to sit there and have a 30-minute training course before I could use it. It's pretty intuitive. I can also personalise it. So if I want my Maps app to, have Billy Connolly telling me the directions, then I can do that if I want. If I want it in a different language, I can do that as well. So this idea that data that exists is easily brought together in a way that's personalised and appropriate underlies how we start to think about health. What if we could do that in health? What if we could provide people with alerts on their wearables? What if we could give them access to their full health record, or the parts of their health record that are appropriate for the care that they're receiving? What if we could use telehealth interventions? What if we could use that data from a register's point of view to understand outcomes for a cohort and feed that into clinical decision making and planning? And what if we stopped thinking episodically and we had a seamless end-to-end interaction with the health system driven by the consumer and empowered by that data? And then if the consumer had the ability to also enter and contribute data, then that would also change the experience. And the thing about the digital experience is that our thinking is that we don't want to buy a single system that does all of that, because if we do, it will be like the Atul Gawande article. I can guarantee that you really won't like that system too much. There was a term that's been phrased in the States around the big investment around EMRs. They refer to them as digital cement. So they were purchased for at a point in time for a purpose. Things have moved on. They are very hard to change. So this agile, iterative, evolutionary approach is where we want to get to. I'll hand back to Ruth.
So when we start talking about emerging technologies in the future, I think we've probably all had experience now with telehealth. And this slide does seem a little bit frivolous. When I said we would need to move towards doing our clinical work in different ways from usual, I was talking about telehealth, and here comes somebody rocking up in their unicycle and supportive equipment. But I think it's a good example of actually being able to understand where we're going together, because if we don't enunciate that, then it becomes difficult to move together. So just as background, I'm the chair of the New Zealand Telehealth Leadership Group. We're coming up to our 13th year, and no, we did not release COVID. It's a 30-member group, and we span the country. We span clinical groups, we span technology groups, and we've got program managers, business managers, we've got a CFO rep, and allied health professionals. It's a whole gamut of folk. And the sole purpose of that group was to promote and encourage the use of best practice telehealth. We've got a resource centre that hopefully some of you have already consulted, and a number of webinars that I know some of you have already watched. I particularly point you towards the one on equity in healthcare, and there's also a good one, I think, on which we did with Health Literacy New Zealand about how to conduct a good telehealth consultation. So you'll find us on that website there. So that was our background, and I don't think we've ever been so busy in the last 12 months. So, we started with a little bit of a hiss and roar anyway in the beginning of the year, and things just got busier from there. So how do we define telehealth? Telehealth is defined as the use of information communication technology to deliver healthcare where the patient and the provider, or the participant and the provider, are in separate locations. So that's actually text, that's telephone, that's video, email. There's a variety of ways we do that. And radiological images, the way we interpret those, send them, beam those all around the world, that's called teleradiology. And the council makes the note that most doctors are already using some form of information and communication technology in their practice, and it's becoming an integral part of medicine. There's also a statement about the benefits of telehealth, particularly focusing on patients in isolated locations receiving necessary care, but also convenience of care. And that's kind of an older model now of benefits. It doesn't talk a lot about the benefits to not physically seeing a patient, because there are some, such as in the COVID period, where you don't actually want to bring a patient into an outpatient clinic or a busy waiting room where they could be exposed to infectious disease. And also benefits to clinicians in terms of, I know that some clinicians talk about being able to extend their practice into their later years in more of an advisory role for telehealth, and reducing travel. We heard yesterday about our rate of carbon emissions. This is Northland DHB's carbon emission profile, and we heard about how our travel impacts the environment. But I'd also like you to consider patient travel and the travel that we do to provide care for patients. So you can see here that this whole wedge here is travel, staff commute, and here's patient private travel. And, you know, when we think about this as well, that slide didn't turn out so well, did it? But let's spare a thought for our Māori patients, you know, who travel further. They're less likely to be able to make an appointment anyway, and their fuel costs are larger, and their carbon emissions are also greater. So, you know, when we start thinking about equity, you know, that's true for how we deliver our healthcare services digitally also. Now, up to 3 years ago, we were delivering traditional video conferencing. This is a picture of one of our rehabilitation clinicians in Thames who comes by video. He has a video ward round once a week, and a number of us have got resus rooms which have videos installed. So we've seen pockets of excellence in regional implementation, all being champion-led, less than 2% of total consultations. Over the last 18 months to 2 years, we've seen software-based tools grow. The technology's caught up with how we want to deliver healthcare, and there's a variety of those tools, but really still only less than 5%. And then came COVID, you know, and if we thought we were already living in a fragmented and complex world, nothing like COVID to really challenge us, but also to try and pull things together. And, you know, just over one weekend, I think we had a very busy weekend, didn't we, Darren? Yeah, just as the GP said, okay, 75% of your consultations are going to go by telehealth. You're going to do them by telephone or video. And it was a huge ask for our GP community. Just over the weekend, they were trying to, you know, grab webcams and all sorts of, you know, it was bedlam, and I imagine that some of you are either GPs or have partners who are GPs, or you know, have seen your GP colleagues go through this. So there was this rapid adoption of telehealth, but almost all of it was by phone. There was, for those people who already had video established, they used Zoom, WebEx or Teams, and they were able to transition, but there were lots of challenges. Not enough bandwidth, not enough phone lines. Patients were really ill-prepared, you know, and clinicians were really ill-prepared. So we spent a bit of time trying to make up packs for patients so that they would understand, you know, what telehealth was. You know, how do you make a consent for telehealth in these sort of circumstances? This is a little segue into the other uses of telehealth, something else we did in the...
I can show you the world when the pandemic has ended. Tell me, colleagues, just when did we last get a chance to change?
You know, when we talk about wellness, that for me was my lifeline. So a lot of emergency departments through Australasia, we all recorded our own little bits of video, and then somebody put them all together. And it did feel as if we were all together at that point. So there are a whole lot of ways that we can use technology in our favour, and I imagine there's lots of you who've gone through similar sort of things with your online communities, if you like. And likewise, this is a photo of my parents, both with chronic illness. You know, my dad's got metastatic melanoma. Some of you may remember him. He's either taught you or maybe a fellow psychiatrist. You know, and his oncologist turned rapidly to telephone, and it frustrated the heck out of him. You know, because he's like, I want to see the whites of his eyes, you know. You know, we often do think, you know, we pigeonhole our patients into who we think will tolerate a consultation by video. You know, we assume, you know, if you're Māori, if you're old, you know, you may not want to have a telehealth consultation. You have to ask patients really what they prefer. But this also demonstrates, you know, pre-lockdown, 7 DHBs were providing 280, we think video, we don't count these well, consultations a week. During lockdown, 12 DHBs, 2,000 consultations. Now we're down to 870. But 16 DHBs, probably the other 4 are doing them, but we just don't have numbers. So that's a report that's come out from Health Informatics New Zealand, well worth reading. And also over this time, we've seen this proliferation of direct-to-patient telehealth apps. So this is a recent article from the New Zealand Doctor magazine. What's that, 1, 2, 3, 4, 5, 6, 7 direct-to-patient telehealth apps, all aimed from general practice. It's really easy to build these. You can build these really, really easily. If you want to build telehealth applications for people with easy access, easy peasy. If you want to build telehealth services to reach those patients who really need it, it's really hard and it's challenging. And that's the bit we need to get to. So we need to look at how they use these technologies and actually build them for the patients who need them. Sorry, what should I say? I think we'll just talk about the COVID-19 experience for the ministry now and NHIP.
So Ruth really talked about the impact of COVID-19 on uptake of telehealth and e-prescribing as an example. We went from about 37% of GPs electronically prescribing through the national broker in February. We're currently around 90% now, and it went from 37 to about 85 in the space of 4 weeks. So huge uptake. The thing that we learnt from COVID was that it's really important to understand how you decide what technology to use. So just because the technology is there, it doesn't mean that you should necessarily spend time and investment on it. And these were principles that were endorsed by Cabinet to support our decision making. So when we looked at technology, we needed to make sure that everything we focused on had an impact on the public health response. We needed to make sure that privacy was front and centre in terms of the design of those technologies. And we needed to balance the public health response with the economic response in terms of how did this really enable freedom of movement. And then lastly, we needed solutions that were feasible, that could be delivered and scaled really quickly. We were flooded with offers of technology solutions from all over the place, from all over the world. Really hard to decide where you put your energies in that context. So Ruth talked about telehealth acceleration. Cloud is a real leveller here. The reason we could respond as quickly as we did was because we had cloud services, we had platforms we could leverage and use really, really quickly. 5 years ago, if COVID had hit, we would have been in real trouble. So those consumer-grade applications, telehealth services, the availability of cloud enabled us to respond really quickly. We also got used to working remotely, so the video that Ruth showed there, I mean, you know, you don't need training in how to use Zoom. Everyone hopped on it and was using it. We from the ministry went from pretty much everyone being based in the office overnight to everyone working from home. And the tech worked. I mean, it had its glitches, of course, but by and large it worked and people found it really effective. We rapidly created some new digital channels. So the COVID Tracer app that I'm the product owner for is now about 2.38 registered users. The ministry's never delivered a direct-to-consumer service before. We had to learn really quickly how you did that, and we made mistakes and we got some stuff right. But back to that digital health definition and the reality, we could iterate. We could iterate quickly. We could put product out there. We could get feedback. We could refine and move forward. And you can do that with all of these tools. Our public health platform, the contact tracing platform, was stood up in about 3 weeks from scratch, from zero. That's pretty quick. In fact, a day after we went into level 4 lockdown, the national contact tracing platform was live. So pretty quick. And what it did for us is it reinforced the importance of those strategic enablers around interoperability, security, privacy, trust, and just some basic foundations. And it gave us a confidence that you can actually try this and you can do it, but you need to understand the problems you're trying to solve. So I'm not clinical, and I wouldn't assume to know what clinicians need, but I have been in health IT for 30 years, so I sort of know that you probably want to start by asking people. You need to understand what those problems are. And sorry, very busy slide, but we created a lot of these capabilities and we're looking to leverage these going forward rather than simply have them as something that was created for COVID and then thrown away. So the COVID Tracer app, we created the Athena app, which was for the health workforce as a way of getting COVID updates pushed to people through an app on the phone. We had a privacy by design approach, so we worked really closely with Office of the Privacy Commissioner along the way. We did a lot around data. I don't think I've ever seen so many dashboards in the sector as I did in about 4 or 5 weeks when we went to lockdown. Every DHB, every practice and the ministry were creating data dashboards. It was pretty difficult because in the background you were sort of wiring stuff together, but it got easier as we used some of those technologies. We had to support these things. So when you deliver services over the internet, which is the only network that is going to allow you to reach the maximum number of people you need to reach, you better be rock solid around your security. And it's a very different model to delivering services on a hospital network or a private network. So we had to learn really fast and leverage commercial capability there. We also had to learn how to support these things. So when you've got 2.3 million people using an app that might need some support, you better understand how you're going to scale that. You also better get it right, otherwise your operational support load is going to drown. And lots of work in the sector, just small things, sponsored data, removing the cost of data charges for key websites, looking at how we can fund access to internet, to data, to systems for people who maybe currently don't have them. And some key enablers, digital health identity. We are currently working on leveraging off of COVID, creating a digital health identity for every New Zealander and for every person in the Health Practitioner Index. So that will be an account-based identity that is linked to an NHI or to the HPI that is available to the sector to be able to leverage. How does the sector leverage that? Or effectively what they are able to do is trust that that is a verified identity that can be used within your organisations to provide access to clinical data or to business processes. So we're working on that at the moment. Interoperability, how do we make data flow? I'll talk about that in a second. And immunisations, major investment happening at the moment around the national immunisation system. Obviously focused initially on COVID vaccine, but ultimately replacing the current national immunisation register, which is a little long in the tooth. So the National Health Information Platform is actually takes a bit of explaining because it sounds like a thing, right? It sounds like we're going to go to the market and buy one of these, and that's the last thing we would want to do. It's really a concept, and it's really talking about that GPS experience. So we've got lots of data. It's in national systems, it's in clinical systems, it's in consumer systems. Ruth talked about the surge in the number of direct-to-consumer services that are out there. There's social data that doesn't even sit within the health domain. nHIP is about bringing that data together and making it accessible through application programming interfaces, so standard components that can be used by products, services and tools to deliver access to that data to consumers and their whānau, to providers, clinicians, to policymakers and planners, and also to industry. So also to the people that develop smart software, giving them access to data in an appropriate way to deliver great product, and ultimately to provide choice so that organisations and people can choose what service works for them, just like the GPS example, but be confident that it's joining the right data, it's getting trusted data. So we've got objectives around innovation, we've got objectives around enabling whānau consumers and their carers to better manage their own care, health and wellbeing. We really want to target equity, so we need to tackle digital inclusion and that digital divide. There's no point standing up great digital services if there are communities that can't get the internet, so we need to tackle that as well. We also need to understand what clinicians need to enable better care and decision making and provide flexibility around workforce. So to that sustainability theme, we think this is really key as an enabler to allow the sector to flex and adapt and evolve to address those sustainability challenges. I won't go through these. We're working, again, back to understanding the problem first. We have crafted 6 problem statements that we think we should focus on to start with, and we're working through some co-design processes on these at the moment. So we think people should be able to update their own NHI details. Seems pretty obvious to me, but today they can't. We also think that all health professionals should be able to access health information for people that are in their care. If you are in a DHB, GP practice, a large NGO, you can pretty much do this already. But if you're a small NGO, quite often you have access to nothing. So we think that needs to be addressed. Medicines is really key, chronic conditions is really key, and we want to make sure that health information is accessible to all New Zealanders. So today the main conduit for that are patient portals through GPs. They tend to be tethered to a GP practice management system, so if you're lucky enough to have a GP whose practice offers one of these portals, then you have access to some data. If you don't belong to one of those practices, quite often you have no access at all. So we think all New Zealanders at no cost should have access to that data. And we also think there's a real challenge around entitlements that we might be able to solve. So today, understanding what people's eligibility and entitlements are for services is pretty difficult because they come from multiple places and the consumer doesn't know. Quite often the health provider doesn't know either. So we think that can be improved. We're thinking about 6 work streams for the National Health Information Platform. Delivery of data, starting with medicines and other trusted sources. Creation of a consumer service and a provider service that's accessible to everyone using those digital identities. And then some of those technology enablers that needs to be in place to make that happen. And then lastly, but really importantly, change in adoption. So there's no point creating access to this data in Molesworth Street in the ministry if you're not incentivising and funding and working with the sector and with industry to make sure they're able to be offered through the services that you all use today. So there's a major focus around change and adoption. And our target is budget 21, so July next year for budget implementation. It was budget 20, and then a small thing called COVID got in the way. But we're now targeting budget 21 for that major investment. We're engaging pretty widely, so I've certainly been presenting on this multiple times currently. Our structure going forward, we really want to engage through existing groups because those groups have the networks, the relationships and the understanding of what makes a difference. And we have a pretty standard governance structure which reports all the way up through to the Minister of Health. And a last mention on digital enablement. So if that's National Health Information Platform, which is about data accessibility, we're also really focused on what we're framing as digital enablement. And that really covers 3 things. So telehealth, how do you use information and communication technology to get healthcare to people when they're physically in a different place. Teleworking, the ability for people to work from any location and get their job done, whether they're health providers or administrators or individuals. And then digital inclusion. So how do we target equity? How do we target the people that actually can't get access to these services? Because if we're not careful, we create inequities by delivering digital capability. And we're focused on a few areas where we've picked these out of a process and said we think we should have a look at these as possible national capabilities. Not necessarily one system nationally, but understanding how we can solve it. So scheduling, as an example, we know is a major issue. You can deliver telehealth consults, but being able to schedule them and manage them alongside your in-person consults is not particularly easy, and it's a real barrier. So how do we do that? We think we need to have a conversation nationally about that. And I think that's us.
Thank you very much. Coming from one of the DHBs that scored very highly on your list, Ruth, Waitemata, I'm convinced that you need a local champion to drive these changes, and we've been very lucky to have Dr. Lara Hopley at our DHB, who's an anaesthetist, but now spends half her time with IT and championing across all groups, and it's been brilliant. But I'm convinced you probably do need a local champion at each site, because she's the one that takes phone calls, emails, any time of the day or night, and will fix things immediately and make things work. And we are virtually paperless now, almost completely. So we're going to go through some questions now, which Charlie will read out.
Just a reminder to have a quick look at Slido and vote for the ones that you would like me to pose. Top of the list is a question from Suzanne. Having one IT system in the South Island has been very useful to have oversight of the patient journey. Why the reticence to mandate a national system for a population of 5 million? Just press.
Yeah, it's a good question, and I guess it comes back to experience. So the first comment would be that in the South Island you don't have one system. You have thousands. What you do have a really solid, trusted source of information that's accessible by all DHBs into general practice and into some of your major NGOs. So Health One is the system I'm talking about. But the system used at the clinical coalface varies from organisation to organisation. The key is that it can integrate in and make data accessible across all of those settings. One system could work, but what we've seen in the US and that article by Atul Gawande is a really good case in point, where one system means standardised processes across every organisation and sort of assumes that every organisation is homogenous, and that there's the ability to have authority to make decisions in one place for all. And we know in our public health system, which is federated, I mean, DHBs are autonomous. So that we really struggle even at regional level to make that happen, let alone national. We've seen national maternity system, we've seen the national Oracle system. They really struggle, not because the technology is not that good, but because, back to the point earlier, you have to start by understanding the problem you're looking to solve. And the problem for a clinician in Gisborne may not be the same as the problem for a clinician in Waikato. So if you're not having those conversations around what are the problems you need to solve for those people in that setting, you run the risk of oversimplifying and having a system that actually works but doesn't work particularly well for anyone because you've got so many compromises.
Thank you. Question from Jeff. A decade ago, exactly the same goals were espoused at NHB and ministry level. We appear to have made tiny progress at best. What confidence can we have entering into 2021?
All questions to me at the moment.
Yep.
Look, I think the reason the goals are the same, it's really back to that digital health strategic framework, is that we all know that we want information to be accessible, and we all want tools that help us to do our jobs. And we know the technology can do it. That's the irony, but also, I guess, why those that work in health IT work in health IT, because you know the tech can do this, or why can't we deliver it? So I think that's the first thing. The goals are the same because the goals are absolutely right. They weren't wrong then, they're not wrong now. The question of what will be different this time is, I think, there's a couple of answers to that. One, we have seen progress, although it may not seem like it. So 10 years ago, for example, Health One didn't exist. We didn't have a Midland clinical portal in the Midland region. We didn't have cloud-based practice management systems. We didn't have a whole range of telehealth options that are available now. I mean, Zoom didn't exist, for example, as a consumer-grade platform. So we have made progress in terms of making data accessible and using different tools. But the other thing that's occurred is that technology's moved on. As I say, 5 years ago, if COVID had hit, we would have been in real trouble. We would not have been able to respond with a national contact tracing platform. We would not have been able to deliver a consumer app in the time that we did 5 years ago. So I think those are the two things for me that are different. And then probably the last thing to say is that we won't get it 100% right, but if you deliver in small iterations, you have the ability to learn and to pivot. If you've got one monolithic big delivery program and you are going down the wrong path, it's really hard to reverse out of it. So that agility is really key.
Thank you. I'm just going to pose this next question to Ruth to give you a break. There's a couple of questions talking about the broader issue of inequities. Alice notes that sometimes telehealth can exacerbate inequities, for example, in mental health. Many of the patients are homeless. And another person noted that Julian Vyas' most recent data suggests that 11% of New Zealand population do not have access to internet. And so both questions are really asking, how can we stop further disenfranchisement?
No, absolutely agree. That number's probably more like 20% in terms of inaccessibility, and that tends to sway more towards folk over the age of 55 and socioeconomic groups. So there is something called the digital divide. You can go, if you Google it, you'll see it on some really nice maps laid out for you. There is no doubt, like I said before, that you can build telehealth systems which are quick and easy to use for people who don't need them or people who want them. Building something initially with an equity focus in a co-design manner is key here, and I think if for us in Waikato, that means that we're designing something locally and involved a number of different groups. So that's the first thing that I would say, and I agree that, as Darren says, that sometimes these things just have to be local, and then we need to learn from those experiences. So that's the first thing that helps address with that equity question. The other things, more practical things like access to data, access to devices. Certainly, again, in our DHB, we're looking at how we can actually do a digital prescription, and there's been a number of financial investments that the ministry have made, which have been targeted at that equity question and that innovation. So there's money out there for this sort of thing, and there's a significant amount of zero-rated data now as well, isn't there, Darren?
There's about 15 sites now. I think the other thing to mention is obviously there's an all-of-government play here. So we're having discussions with Department of Internal Affairs around a universal basic internet concept, which is that today, in terms of a digital public service, if you have people that actually can't access these services online, then you have a major issue for your citizens. So we're talking about the idea of, can you at a government level ensure that everyone has access?
But I would go back to that. If you're going to build something, the best thing to do is to aim at those people who can't actually get access already. Because if you just build it for your average Joe Blow, it'll be really difficult to go back and get that equity lens on. So it has to be equity first, in my opinion.
And just to segue from that point, a couple of questions here picking up on actually the access for clinicians. Alice notes that during lockdown, everybody in her team had to use their own personal devices because the DHB issued devices were incompatible. So a question there as to whether the Ministry of Health would actually look to fund the right hardware. And another sort of related question, noting that when they work in a national service, they have electronic access to the EMR of 5 DHBs, but usually only when they're on site. So how can that allow virtual clinical activity to be done efficiently or safely?
So this is one of the challenges of our health system, right? So in terms of who delivers technology within individual health organisations, whether they're DHBs or GP practices or NGOs, the technology are delivered by those organisations. So I can talk from a Ministry of Health point of view. When we went to level 4, the Ministry of Health almost overnight issued people with devices, monitors, keyboards, chairs to be able to work from home. I can tell you that was happening at an all-of-government level, and there was major pressure on supply chain around that. So is the ministry likely to fund DHBs around around laptops and devices? The honest answer to that would be no. Do we recognise that there are challenges around the technology that is in use today within district health boards and other health provider organisations? Absolutely yes. So the National Asset Management Program and the Health and Disability System Review both have called out significant underinvestment around technology within health organisations, and that's absolutely a problem that has to be addressed. Question of how, almost back to the question to the Minister of, are you going to give DHBs more money? The question of how is still to be resolved. But if I think about that digital future and I think about sustainability, if information's accessible but clinicians can only get it when they're sat at their desk in a hospital because it doesn't work across the internet from home, it doesn't work. You've got to tackle that for clinicians as well as you do for consumers.
Any comment from you, Ruth, or no? No? Okay, all good. So Siobhan also notes, and this is a similar issue, that the average private organisation spends about 7% of operating budget on IT, but the average DHB spends less than 4%. So obviously that's an issue.
Yeah, I think it's actually wrong. I think the average DHB spends about 1.6%. It's significantly worse than that, and this is a major challenge. And this is, you know, when you're an organisation that has multiple pressures on your funding, in terms of delivering clinically safe care, in terms of your building real estate and some of the issues there, in terms of changing models of care around consumer expectations, burden of chronic disease, workforce challenges. You know, I'll constantly advocate for more money into technology, but I'm probably a little way down the queue, to be honest. But it is again, it's a major issue. Yeah, we do not invest where globally and in terms of other industries we should be investing.
And I mean, I think the corollary of that is that actually it's the responsibility of everybody in this room to be advocating for the digital tools that we need to do our jobs. You know, I think that's really, really important. So, you know, and likewise, when we're looking at new kit, you know, thinking about the consequences of that, you know, radiological devices are a really good example, but there's lots of other ones. You know, even buying things like 3D printers, how's that going to integrate? There's so much tech now. We go to conferences and we see all these wonderful, fantastic things. Certainly in my place, I see different services getting different bits, and then all of a sudden there's this, you know, need to plug it in somewhere because we haven't thought of that, because we've been sold something that just, you know, kind of should work, but won't with the other bits to go with. So, you know, I think having a really, you know, if you're going back into your DHBs, have a think about where clinical informatics sits as positioned in your structure. Are there ways you can feed back? Is there a local clinical informatic reference group? I think the point that, you know, has been made from the Waitemata, one of the reasons they've done so well is because they've allocated resource and clinical time into those roles, not just from an SMO point of view, but from an RMO, nursing, allied health perspective. So I think we all should take that challenge back. It's not necessarily a ministry thing to solve, I don't think.
I just add one comment to that. So in terms of that COVID response, I mean, the really interesting thing with that is that we delivered solutions because we could leverage cloud and we could leverage the technology that was there. We delivered solutions for probably less than it would have cost us to have done the business case in normal times. And there's a real learning in that. So one of the other things I'd encourage, and we're certainly doing it from inside the ministry, is that actually when you can leverage these tools and iterate quickly, you can demonstrate what you can deliver and also demonstrate where the gaps are far more effectively than if you write a 200-page business case and try to get it through the multiple sign-off stages. So I'd encourage you to be looking at that as well within your organisations.
And it's another very relevant way that we can try and reduce our ever-increasing CME balances quite legitimately with these various tools of the trade. If you feel you have to have it, use your money.
I'm going to summarise a few questions because we're running out of time, but there's quite a few talking about the need for better integration, particularly between dental records, also primary care and secondary care medical records, barriers to sharing patient data in a safe format. Have you got any comments on those issues?
I agree. I mean, this is at the core of what that National Health Information Platform is about. We have data, but it's locked up. It's in silos, and there's technology and also non-technology barriers around the ability to access that data and bring it together. So we absolutely agree. The question is where you start. We do think that primary care is a place where we really need to focus, and then there's key information like medicines, like diagnostics, that we think we really need to focus on, like immunisations. Yeah.
Cool. Thank you. And I will finish with John's question. It's good to see that Southern DHB doing well, developing digital health. We had a very strong CIO a few years ago, but he also stole $30 million. How do we avoid the massive frauds that seem to plague the health IT sector?
I'm old enough to remember Mike Swan. So, yeah, look, I mean, the simple answer to that is that that's why we have processes, that's why we have diligence, and the key thing in terms of moving quickly is that you can leverage these tools and you can now invest in really cost-effective tools and deliver gains, without siphoning money for a boat in the harbour. Yep.
I'd like to draw this session to a close now and just like to thank Ruth and Darren very sincerely for coming up here and telling us so much about where we are going to be going soon. Thank you very much.